All right, today, as everybody sees, we've got Charlie Resnikoff coming back. Again, the leading echo speaker of all time, and usually gets the biggest crowd. He's going to be talking on 5 key topics on addiction medicine. This is a talk he's going to be doing for the American College of Physicians, so should be great. And everybody knows Aaron Boss, my co-facilitator.
So we have some really great talks coming up on the schedule. Our next session is to be determined. So if anyone wants to scoot on in and give an echo presentation on anything interesting that's come up, please let Katie know. We'd love to have you, or if you have any suggestions. Otherwise, I think Kurt's probably going to get voluntold into doing it.
Actually, I'm working on a talk on Suboxone as a mental health drug.
All right. As long as you have a plan,
I love these.
All that matters.
I love these quirky things, Charlie. I just, it's just kind of a weird talk, but it's like just really interesting.
So we have Cole.
So yeah, we've got really talks for quite some time. So this is just one funny gap.
Yeah, we've got Cole Perringer coming up, and then Haley Hillstrom and Troy Green from HIDA to give some updates on drug trends, and then Rick Moldenauer on some of the updates on methadone in Minnesota. And then if you also have interest in checking out any other echoes or need some extra CME, check out the links at the bottom of this slide.
All right, remember there's free CME, and remember, if anybody loves to have your face on the echo, it's Charlie. So feel free to turn your video on so we can talk to your face and not that black box. Remember, when Katie sends you that stuff about the CME, fill it out or you don't get anything. So it's free. It's free.
We're here for you for any of your technical assistance needs. I will say, reach out with any interesting cases, policy, protocol, any needs like that. Kurt always jokes, don't text us about your personal problems. We can't help you. But I will say, I made some bomb chili last week. So if anyone wants a recipe, you can text for that, because I was impressed with myself over this chili. It was pretty good, and it's chili season.
I hate chili. But anyway.
What?
Yeah, I don't like chili. It's those beans, you bite them, it's like a beetle. But anyway, so, and if you need more resources, you can go to CORE, the website, and all kinds of different things on there that are always being updated. So feel free to check that out if you need something. Don't reinvent the wheel. And now we'll let Charlie share his. Are you going to share your screen, or you want Katie to move these?
I can share.
Okay.
Either way, though. Yeah. Well, by the way, do you know there's something called there's a word for it, the chili bean border or something, basically down the Mississippi River, everything to the west of the Mississippi, there are no beans in chili because they've got enough cattle, right?
I'd eat that.
Yeah. So chili west of the Mississippi, no beans. Chili east of the Mississippi, they needed something to kind of extend they needed to put something in there because they didn't have enough beef. So beans and chili is east of the Mississippi. And remember, and I don't know, Aaron, how you feel about this, in chili competitions, if you can look in the chili and see a vegetable oh, that's an onion or that's a green pepper, it's disqualified.
Huh. Wow, I would have been for sure, because I like mine chunky and with tons of vegetables and beans. Yeah. But that's so interesting.
Dr. Drum just said in Texas it's only meat, and I think we expect that, right?
It's meat in a sauce. Yeah. So I had a partner from Texas once, and I was at their house and we were talking about chili, and I had a vegetable-y chili with carrots and lentils and celery and stuff like that. And the father of my partner said, "That's not food. That's what food eats." So it's don't feed me carrots, feed me cows. The cows eat the carrots. I eat the cows. Anyways.
That is funny. Well, you could always substitute with green peppers or whatnot. Is that allowed, or is that?
You can put it, by the rules, if you can see a vegetable in the chili, it should be a sauce where there's the meat that's tender and delicious in it. Wow. And then beans if you're east of the I mean, nobody follows those rules, but
I don't like it. I don't
that's
like
the
those
rules.
rules.
No beans in Chile and Colorado.
Yep. Yeah. West of the Mississippi, no beans. That's okay. Anyways,
Well, we could probably end the echo now that we've all learned something. But
I'm literally making green chili today as well for my dad. So, there you go. So let's see. Can you see that?
perfectly.
Okay, cool. Yeah. So let's just get on with it. So I was asked to think of 5 topics that I think are really important topics to share with just a general medical audience. So you all are more than that. You're more expert than the audience I'm going to share this with. So we could go into like detail or debate, or you could give me feedback or want to add or change a topic. I welcome those sorts of feedback. And these are the 5 topics I'm thinking about: overdose death rate, stimulant use disorder pharmacotherapy, counseling people with substance use disorders, and adulterants and novel drugs, and preoperative alcohol assessment. Those are sort of like the 5 topics that that are very on the front of my mind that I think we can do better. We have tools to use to get better at this, but we need to get better. So we need to get better at these, and we actually have tools to do this better. So overdose death rate. I've talked about this before on Echo. I'm sure you all are aware of this, and you've talked about this. It is not a statistical fluke. I think this is really happening. Like, death rates are actually, for the first time since maybe the 1990s, opioid-related death rates are going down. I mean, obviously, it's still unacceptably high death rate, but their death rates nationally and in Minnesota are decreasing. So if you look at Minnesota, it's right kind of in the middle. We're average. We're average. We're right kind of in the middle in terms of change from 2023. And 2023 was better than 2022. So we're in a couple year streak here of reductions, and we're reducing overdose deaths by 10, 11%. And then here's again, this is more data. If you look at this is for the January to August rates. And man, I mean, the 2022 and 2023 data is like finalized. The 2024 data is still considered preliminary, but wow, look at it. I mean, so there's lots of things that could be going on here. So why? Why is this happening? I think we can all acknowledge it's a good thing, but why? And so I'm going to go into some of my responses to why. Some of these I may have presented on Echo before, but I think it's worth mentioning. Naloxone availability is definitely part of this. But if you look at, this is the latest data from suitors that I could find. But if you look at overdose deaths, and then how many of them are opioid positive, that's green. The green bar is opioid related overdose deaths. And then how many had a bystander present? So a lot of people die alone. Okay, that is intervenable. If we can teach people to not use alone, then we won't have people dying alone. And then of the bystanders present, naloxone was only administered, and these are deaths, so this doesn't count for the saves, but naloxone was only administered less than half the time, like 40% or less of the time. So even though naloxone is almost certainly helping the overdose death rate, we got a long way to go. We need more people present when there's an overdose. And when they are present, we need more naloxone present. And so the good news is if we continue to optimize naloxone, we could see even more benefit on the overdose death rate. So again, bystander present and naloxone administered. We are far off target for those. Naloxone is administered less than a third of the time someone dies of an opioid overdose death. That's a lot of room to improve. The other thing, and it's going to be a little distracting. My email might ping every once in a while. But the other thing that I've talked about before, which I think is just a really interesting cultural change in drug use, is that people are injecting less and smoking or snorting more. Fentanyl. So fentanyl use is less and less injection. And particularly from 21 to 22, and this is an ongoing trend, it's not just the relative numbers, but the absolute numbers of injection decreased from 21 to 22 and just a little bit, but then also the relative, rates have decreased where it's really smoking is the commonest now, and eating pills and snorting are second and third. So injection is the fourth leading way that people use fentanyl, whereas just even back in 19, it was the leading way. So it's weird to say that's a good change. That's a good change. Why would that be? I think it's because fentanyl is so potent that you can get your fix, if you will, by smoking, eating, snorting. Any way you ingest this stuff, you can kind of get your desired effect from it because it's so potent that it can be adequately taken without having to inject. Why do people, another way of saying it is, why do people inject in the first place? It's usually their tolerance gets so high that they need to overcome their high tolerance. They need a higher and higher and higher dose. You can get that from injection.
Charlie, there's already something in the chat, and Kat was just saying, is there any correlation, you think, to decriminalization of smoking paraphernalia?
Oh yeah, that's a great point. That there may be, both decriminalization and just widespread dissemination of all these vape pens, of all these. I just think with the cannabis legalization, there's much more availability of all this paraphernalia, and a lot of it's legal, or at least you could say it's so I agree. I think we have a lot more drug paraphernalia, smoking paraphernalia around. I think that's true. That's a great thought. Yeah. So I think overall this is maybe a byproduct of how potent fentanyl is, and maybe also paraphernalia availability and legalization. But I do think some of the paraphernalia legalization happened after this change. I think that's only recently, in the last year or two. And this trend was already happening before then, but certainly it doesn't hurt to have legal paraphernalia. So, okay, so, great. So,
Charlie, there's another question in there too, and it's from Kelly. Looking at the data quickly, does the data you just showed also mean that about 1/3 of the deaths people did not get naloxone but died?
Did not get.
Actually, it made me wonder. So there were 4,100 deaths, 1,000 got naloxone but still died. Am I reading that right?
Yeah.
Okay.
Yep. Yeah. So none of these are saves, and there's probably 10x this number saves, or 5x or 10x. I think it's a pretty high ratio of overdoses that are non-fatal. I think there's actually quite a lot of non-fatal overdoses. We're not even counting them all. Like, a lot of them happen out there and we don't even know, but there is a lot of non-fatal overdoses, and Narcan is certainly helping a lot of those. But yeah, these are deaths despite getting Narcan. So I don't know if I'm answering the question.
Yes, you did. Thank you.
Okay. Yeah, this is just more data to show the change these are deaths. Again, deaths. And people do still die of smoking fentanyl, but the ratio is changing so that, again, injection is decreasing and smoking is increasing. So this is, I think, a really good thing. The other thing I want to focus on, why deaths are decreasing and things we could do better, is this is more state data that I think is really important to look at. If someone is released from an institution and then immediately has an overdose, where are they released from? So, a lot of people talk about, if you get out of residential abstinence-based treatment programs, you're at high risk of death after release from an addiction treatment program, especially if it's an abstinence-based program. So you can see down here, to answer the question, in 2022, 28 people died shortly after release from a treatment program. I think but I want to highlight, and the vast majority of patients who die are not recently released from a program or whatever, or released from a facility. Most of them are just out there in the community using and they die. But I want to focus on two things. First, if you ask people like in a multiple choice question, most people would say getting out of jail is the highest risk time for an overdose death. But interestingly, in Minnesota, it's actually not doing too bad. And I would just want to give props to Tyler Winkleman and his group, Rachel Silva and their group at Hennepin County Jail, which is, you could think of Hennepin County Jail as the biggest treatment program in America, in Minnesota. I think recently I heard they have over 100 bupe prescriptions per day. I think I heard Tyler say 120 bupe prescriptions per day. Plus they're doing methadone. So Hennepin County Jail, which is the biggest jail system in the state, is fully providing MOUD and doing their best to discharge people with a safe plan. So I just give them some credit for why this number is so good. But it's not just Hennepin County Jail, because I know Kurt's been involved in the criminal justice system in terms of treatment, and there are efforts all over the state to improve incarcerated people. First of all, don't incarcerate them if you don't have to. Drug court, decriminalize marijuana, etc. If they are incarcerated, give them the treatment they need. And so Hennepin County Jail gets credit, but I think county jails throughout the state are really doing a good job of this. So I think a lot of people, though, are surprised to say, what, after people go to the hospital and then they get released from the hospital and then they die of an overdose? If they're in the hospital, and that includes the emergency department, we should be able to assess for opioid use disorder and treat it. What is the problem there? And I think that's a huge frontier, honestly. Hospitals, emergency departments, getting to almost like a quality metric. If you have a heart attack, a myocardial infarction, you go to that hospital, you're going to leave that hospital with a statin, a beta blocker, an ACE inhibitor, an aspirin, nitro. There's like a checklist. You're not leaving that hospital without all the right things that will prolong your life and help your recovery. But we're not meeting those levels of care for opioid overdoses. And so getting our hospitals in line is like a huge thing for us. And this is just another piece of evidence that every hospital, every emergency room really needs to hold itself to the same standard with opioid overdoses as with heart attacks. And right now, if you have a heart attack, your 1 year mortality, your chance of dying in 1 year, is lower than if you have an opioid overdose. What is your 1 year mortality? You're more likely to be dead a year later after an opioid overdose than you are after a heart attack. And we have tools for this, and we're just not using our tools. So you get my point. We've got room to go. And then I think there's an interesting debate about fentanyl and how fentanyl poses unique risks. And I've been thinking about this a little bit. So fentanyl is in 15% of cocaine or methamphetamines, 10 to 15%. So it's adulterated. Anything that looks like a pill on the street, you should assume has fentanyl. And fentanyl is the primary substance that kills people in America by far. I mean, it's not even close. So is fentanyl just another opioid? And I've just been thinking a lot about this. Fentanyl is self-administered more often. So it's used more frequently throughout the day. And I do think that creates a worse behavioral addiction. You're the behavioral habit, just like we smoke cigarettes all day long. That's a very powerful behavioral habit. We're using fentanyl frequently throughout the day. It's also more potent. So that creates a higher tolerance and more severe withdrawal. That makes it more problematic. It's more lipophilic. So there's a lot of weird, funky things about how long it lasts in the body. And that depends on whether it's a one-time use or repeated uses and your, adipose tissue, your fat tissue in your body. And then finally, related to probably all these things, precipitated withdrawal is more common in fentanyl users than in other opioid users. It's still manageable. The highest percentage I've seen is 12%. That's pretty bad. The lowest percentage I've seen is 2% of fentanyl users will experience precipitated withdrawal when started on buprenorphine. So I do think fentanyl is different. And I don't think we say it's just another opioid, but I also think it is treatable. So this was an interesting study that looked at fentanyl users who were on different doses of buprenorphine and their likelihood of coming back to the emergency department or being hospitalized for an opioid-related harm. And you could see clearly, well, I have said before, greater than 16 milligrams a day. And now for fentanyl users, I'm getting pushed up to 24 milligrams a day with studies like this. People on 24 milligrams or more a day of fentanyl are clearly coming back to the hospital less commonly. They might just need a higher dose. And I'm a crusty old timer. My first buprenorphine induction was in 2006. And we used to think of the 24 milligrams as never. I was 8 milligrams for I had a lot of patients who started back then. They're still on 8 milligrams or 4 milligrams. They're doing great, but they were never fentanyl users. They were using oxy or other drugs. So 24 milligrams, and this is a study, again, 24 milligrams versus 16 milligrams. And survival here is not life or death. This is retention in treatment. That's what they mean by, it's like a research term. They're not they're all, it's who stays in treatment. So I think we're starting to get up to give them 24 milligrams a day for a better outcome, which is hard for me as an old timer who didn't used to do that. So that's just a quick opinion on why opioid deaths are decreasing. Naloxone availability, we can do better there. Fentanyl is now being used as smoking, eating, snorting. That's a good thing. We should encourage people not to use IV if possible. Buprenorphine availability and dosing, we can do better there. Reduces cycles of incarceration and overdose, whether reducing incarceration or just treating incarcerated people. We are doing good there in Minnesota, but we can continue to do better. I think people are just figuring out that fentanyl is nasty and using caution. That's just an opinion. And there's a chance that there's some statistical thing. Maybe we're filling out death certificates differently. Maybe that's it. We've got fentanyl fatigue. Maybe COVID caused a surge in deaths, and now we're just statistically regressing to a pre-COVID death rate. I don't know. So there's maybe some statistical things happening there, but that is point number one. I'm going to move on to point number. Go ahead.
Charlie, couple questions. Somebody just asked, Jessica did, said, are you finding patients where 24 milligrams isn't enough?
I mean, I think the group I work in, like Brian and Lauren and Kitty, I think they are. And I think we are now. I mean, I usually try to keep it to 24 personally. But I've always been on the stingier side of the frankly. I mean, I think I need to get a lesson. I just need to get my practice up to 24, or at least listen to patients. I think I would take a patient-centered approach. And these studies, one of them was 24 milligrams. One of them was greater than 24 milligrams. I think my understanding of bup is that pharmacologically, if you get up past 32, you're just not going to be doing much. But I would listen to patients, and I would go up above 24 if that's what the patient's telling me and the clinical circumstance looks right. So yeah,
One more question before we move to stimulants. Somebody asked whether you could say more about the numbers, why they're higher after release from hospitals.
Well, yeah, I mean, I think so. Remember that Prince was on an airplane and had an overdose. The airplane landed. They rushed him to an emergency department. They gave him Narcan. And then he left that emergency department with no MOUD or treatment. Now, that might be Prince's choice. Who knows? But then he left with no MOUD, to our knowledge. And he then had another overdose within a week, 1 week. And what happens in emergency departments with EMS calls, with hospitalizations, is that they have this acute care encounter for an opioid-related harm. We fix it immediately, but then we don't start buprenorphine or methadone in the hospital, in the emergency department. They don't leave that encounter with a prescription for buprenorphine, and then they have a subsequent overdose. And the 1 year mortality after a non-fatal overdose is something like 10%, but actually a lot of that is clustered early on. The immediate risk after an event, a near miss, an acute care visit, and then they go right back into their community. If the equation isn't changed somehow, they're high risk of having another event. I think what we need is to have them leaving the acute care facilities with bupe in their hand. That's easy to say, but what the reality is we need hospital emergency department staff ready to do low dose inductions, to know when to give the full dose, when to give the high dose, when to give the low dose, and how much to send them out with, and how to counsel the patients. And I think a lot of emergency providers just don't have that training yet. And I think, and same with hospitalists. They just don't know how to start buprenorphine on an inpatient unit, and we need that. And so even our inpatient consult teams, I don't know, a third of our inpatient consults are just help me start buprenorphine, and it actually is a little complicated because they don't want to have precipitated withdrawal. The patient doesn't really like buprenorphine. It takes some counseling. It takes some work. So yeah, that's my answer. Other questions?
There was one last one about how are you getting these higher doses approved by insurance, and that has been a bit of a challenge, especially if you go to 32. At 24, I guess I haven't had troubles. Have you?
I haven't had a ton of troubles, but I will also say that the Opioid Epidemic Response Advisory Council, OREC, which I'm on, has a sort of a process of making legislative recommendations. And I am asking OREC, and I have some colleagues helping, on my side on this, to try to change our state law to make prior authorizations illegal if a FDA-approved treatment for opioid addiction is being prescribed. Like, why are we creating barriers for treatment of opioid use disorder? These are FDA-approved life-saving treatments, and we're creating barriers. Right now, there is a law that makes PAs illegal for certain types of medications, but those are not extended to treatments of opioid use disorder. And we're trying to extend that law to include basically buprenorphine in all its forms, we're thinking about including Butrans and Belbuca that can be used for low dose inductions. So to your point, and Sublocade is a total quagmire of PAs. It's miserable. And if you get the PA wrong, your clinic will lose $1,000. It's just insane. It's miserable. So we got to clean up this PA problem, and I think it can be done. It has been done for other types of medications at the legislature. And I would just say, if you have any ability to get behind a legislative process, email me. I'll show you the actual current law and some proposed changes to get that law to make buprenorphine PAs a relic of history. So anyways, anything else? Okay, I'm going to move through this kind of quickly. I think you know all this, but I think understanding what we can do with medications for stimulant use disorder. I've showed this a bunch. This was partly done at my institution. Hennepin County Medical Center was a site for this study, and then they are now redoing the study. They're doing this again to sort of confirm the finding. It's annoying as a study in some ways, I'll just be frank, because the buprenorphine dose is very high, and the naltrexone, intramuscular naltrexone every 21 days, talk about PA. try to get an insurance company to cover that. They won't cover IM naltrexone for stimulant use. So you'll be looking for another use disorder like alcohol or opioids, even to get it covered in the first place. And they won't be covering it 21 days. So it's just not helpful. But you have to extrapolate from what they did pharmacologically to see whether you can find something you can do in the clinic that would be helpful. For people who got this almost impossible to prescribe regimen, 15% of people used less methamphetamines. They still used, but they used less. Here's the other interesting things about this study. These were severe meth users. These were heavy daily, these were not casual meth users. These were really severe users. So that kind of reflects nicely on their outcome. It's a really well conducted, that's a real finding because the study was well conducted, and these are very seriously addicted individuals. But the other component is this is a bit of a contingency management therapy, which we know contingency management helps as well, because these study participants were paid some like money or gift cards to show up and take their medicines. So that's not really realistic for our clinical setting. They had like a 95% attendance rate in this study because they were paying people like a contingency management therapy to show up for the study. So in some ways, this is a very extreme, heavy using population, and that's helpful. And in some ways, these are medications we can prescribe, but in other ways, these are doses and regimens that we don't prescribe. And they had a 95% show rate in their meth using population. Nobody has that in real life. So, but I would say I would add to this that there are many studies of bupropion for cocaine and methamphetamines that show benefit of bupropion. So that's handy. So I use bupropion all the time, and I believe I have seen clinically patients report, not everyone, but some patients say bupropion helped. I also, it's interesting to know we are now studying buprenorphine for cocaine addiction in our institution. Buprenorphine for cocaine addiction. And the study is excluding opioid users. So this is cocaine use only. Wait, stay tuned for that. I'm a crusty old timer. I think, no way. Why would that work? But it's being studied, and there is some signal that we may, in a couple of years, be prescribing buprenorphine for stimulants only. And some patients have told me that their buprenorphine dose, I've had patients who, when they went up on their buprenorphine dose, they were able to stop stimulant use. And that didn't make sense to me, but it seemed to work. I don't know. So bupropion, I use all the time for stimulant users, and buprenorphine is being studied. This, I think, is, go ahead.
Charlie, of course, someone did ask about GLP-1s,
Oh, yeah.
And then,
for
of course,
sure.
We're all waiting, right?
I think it's most reported for alcohol.
Yep.
But I think we're getting there with the alcohol. I kind of believe it. I'm not sure. I would say this, if I had a patient who had obesity and alcohol use disorder, I would say, hey, look at those meds. Look at the Wegovy and the whatever, the GLP-1, meds, because that could really help you in more ways than one. And so I would definitely encourage people with obesity and alcohol use disorder, but it may even be beyond that. And that's really exciting. But how many times in our careers have there been some magical cure-all and we all jump on board, and 5 years later, we're like, whoops, Yeah. I mean, vitamin D cured everything 10 years ago. Now it's, so proceed with caution, but I'm excited. I don't know about you all. I'm not ready with stimulants yet, but I'm excited. Mirtazapine, I now offer this all the time. This was studied in the men who have sex with men community who use methamphetamines, but I believe it's probably generalizable to a general methamphetamine using community. And this was a more realistic study where it's like there was a dropout rate in this study and people were maybe not ideally medication adherent. but still just give them 30 milligrams of mirtazapine at night. That's a very reasonable dose. It's going to be covered by insurances. And there was a significant reduction in meth use. It's not perfect. It's a reduction. So I love this. I think it's a great option. And now our inpatient units, this is a sign of, I don't want to be cynical, desperation. We're even using topiramate. And the signal on topiramate is pretty weak, but there is a signal that topiramate reduces stimulant use. And we're using it because, we're just going through our options. Have you tried bupropion? Do you want to try add the naltrexone to your bupropion? Have you tried mirtazapine? If you're not into any of the above, let's talk about topiramate. That's kind of how we go. And, and we're doing this. And if someone has ADHD and stimulant use disorder, we do have a few providers who will cautiously do a clinical trial of psychostimulants in that population. And there are some patients who do real poorly, but there are some patients who do real well. And it's, the recommendations and this ASAM guideline is where I would look for more references on all of this, is make sure you're ready for this. So probably this is an addiction specialist taking this on. Don't casually give psychostimulants to people with stimulant use disorder, but there is a subset of people closely monitored who can benefit. So we're doing this as well. And the final thing is consider cardiovascular risk in stimulant users. Cocaine and methamphetamine users have significant increases in cardiovascular and cerebrovascular events. They have strokes and heart attacks. So should you be looking at giving a statin to these folks? No one can answer that with evidence, but it's kind of like a harm reduction thing. If it's something they want and they're at risk of a heart disease anyways, think about heart disease, strokes, cardiovascular disease in these folks, and you might be able to help save their lives, even if they keep using drugs. So that's what I think with pharmacotherapy. Anyone want to comment before I go on to the next segment?
Charlie, correct me if I'm wrong, but to me, it's always seemed like you get about a third of people who just respond to whichever of those drugs you use. About a third of them they don't know, and about a third of them there's nothing, right? So often we're switching around, kind of hoping that we hit it rich.
Yep.
But so it's probably gambling. But that's kind of been my experiences. Sometimes you're really surprised, and I've had people even on topiramate stop smoking, stop drinking, everything.
Yep.
And then the next person, nothing.
Yeah. So the process in clinical practice is, first of all, you have to sort of like manage your anxiety that this person is still using methamphetamines and they're coming to see you and you feel like a failure. Like you will feel like a failure for the first 6 months, maybe, because they're still using methamphetamines. They show up not looking great sometimes, and yet you keep inviting them back. You keep and you keep working with them, and you do some trials. And the other thing is, you think you did a bupropion trial, but in reality, they never really took the med. So you didn't even, they said, no, I don't want to do that because they're using meth and they're not the best, most reliable historians as patients. That sometimes you do a medication trial and the patient doesn't even really give it a fair try. And so you cross that one off the list, but a year later you come back to it and it works. So even in the same person, I've had medications be told that didn't work for me. And then they try it again and maybe they've changed, or maybe they're giving it a more fair trial and it works the second time. So yeah, you're cycling through these options, trying them, you keep inviting them back, and you just have to deal with your own anxiety that this person is still using meth and I'm not seeming to help them, but you just got to keep trying. And then while you're doing that, all the harm reduction stuff, try, the syringe programs, the fentanyl test strips, all the rest of it. So yeah, I don't know if I answered, but that's kind of how I would see it.
There was one other question from Dr. Drum. She says, do we know how people feel about bupropion in the setting of concomitant stimulant use and AUD, right? Because of the high doses and then the interactions with the alcohol.
Yeah, well, so the bupropion is, I'll try to answer that. It's a really good question. Bupropion is like one of these weird meds with a lot of specific contraindications and concerns, seizures. I mean, actually, I think it's maybe less of a serotonin syndrome risk than some of the other antidepressants. So that's kind of nice because it's really dopaminergic. But a person can get pretty yeah, I mean, in theory, I'm worried about them stacking their meth and their bupropion on top of each other. And then if they're in alcohol withdrawal and they're prone to having seizures, or if they're in alcohol withdrawal and they're got some, sympathetic sympathetic tone on that as well. So, yeah, I mean, I think there are some ways that I do worry about bupropion with some of these folks, making them jittery or not interacting well, but I do it with meth users. Like I give them bupropion, and some of them will just say, I don't like the way that makes me feel, and they'll stop, but I haven't had major adverse events other than the things we already obviously know: bipolar disorder, caution; renal failure, caution; seizure disorder, caution. Might add 5 millimeters of mercury to the blood pressure. That's I kind of go through that process. You definitely want to know if they're pregnant, so I just go through that process and I try it and I let them kind of manage that on their own, and if they don't like the way it makes them feel, they'll just stop it. I don't know if that helps, but, okay. Can I dive into the next?
Do it.
I think counseling is huge, and I don't think we talk about this enough. So I've been with the fellows that rotate through here, I've been trying to make sure I always go back to the basics on counseling to make sure everybody feels like they know how to talk to someone using substances. So here's my quick, it's like a quick overview back to the basics on counseling. Commonest mistake, I think, they are intoxicated and you're trying to counsel them. You got to limit how much time you spend counseling an intoxicated person. The cocaine user is going to argue and escalate. The alcohol user is going to forget, so it's just the opioid user is going to fall asleep. So no one's going to respond to this. So just before you start down that road, ask yourself, is this person in opioid withdrawal? Keep it simple. Is this person really high on meth? Yeah, don't go into all this stuff right now. Invite them back when they're ready. Make sure they get home safely. This is really obvious. Everyone here should be good at this, but 5 seconds into your counseling, you say the wrong thing and the person's done with you. Just done. And I've been there, even though I should be better. I've made these mistakes. Always letting the patient describe their own substance use and using their own description. Adopting the words they are comfortable with is the key. So just you're gonna turn them off real quickly if you use the wrong words. And from one person to the next, it's going to be different. Some people want to use the word alcoholism. Some people, heck no, they do not want that word used in their presence. And I think one of the hardest things for patients, this is like motivational interviewing, one of the hardest thing for providers is it makes me frustrated. I want to just tell you what to do. You're making the wrong choice. I want to take the choice away from you. I want to try to get you to do what I want you to do. It is frustrating to me when you make a bad choice. Well, if you want the patient to make a healthy change, if you want them to make the right choice, you need to empower their ability to make a change or make a choice. In other words, you need to empower their agency. And in order to empower them, they have the power to make a choice. I'm trying to help you make the healthy choice, but in the end, it is your choice. If I don't believe that, I'm just undermining their ability to make a good change if I don't believe they're able to make a change. And then we're in a tug of war. We're in there's a power dynamic. I'm trying to control you. So the first thing you have to do is accept that they might make a choice I don't agree with, that I don't think is healthy. But if I don't accept that, then I got no starting point for getting them to make a good choice. So anyways, long story short, empower their agency, even if you don't agree with their choice. Ask the patient about their goals. You can't counsel someone if you don't know what their goals are. Otherwise, I'm just projecting my goal onto you. I want you to be healthy because I think your family wants you to be healthy. Well, that's what I'm guessing. Is that your goal or not? And if they have a choice and they have goals, that's the starting point for making a change. And then once you know that they feel they're empowered to make their own choices and you know what their goals are, then you work with them on that and say, okay, how is the substance helping you or hurting you obtain your own goals? And then this is kind of the meat of it. I think almost every person who has a substance use disorder falls into one of these categories. Everybody does everything. Everybody does all of this. But people predominantly fall into one category. So here are the categories. They're emotional drug users. I use drugs when I'm stressed out. For someone who uses drugs when they're stressed out, help them manage their unwanted emotions. Like I would listen to them there. I use drugs when I'm stressed out. Okay, let's talk about stress management. How can I help you with that? I think most people can work with that. Other people, it's not about that at all. They're like, it's not about stress. It's about people, places, and things that trigger me to use. Whenever my old college roommate comes around, we go out and we drink all night. Or whenever that one person who used to be my cocaine drug dealer knocks on my door, I open the door. Before I know it, I'm using cocaine. Whenever my Social Security disability payment lands in my bank account, that's like I just every first Friday of the month or whatever it is, I have always gone out and partied that weekend for the last 5 years. So how do I manage, or whenever my work paycheck lands in my bank account, I always go out and party. And my friends know it and they call me on that day. So those aren't emotions, those are triggers. And then finally, there's I think the hardest person sometimes for me to deal with is the hyper rational person. I think I can figure out a way so that I can use drugs, but have it be in check. So I'm going to do this and that. And as long as I plan this out and I'm going to do just this amount in this time, and I'm going to have the whole thing planned out and I've got it figured out. I know how I can have my cake and eat it too. I've got the master plan. And they'll just be rational. They'll just be logical when they're talking to you. Well, that needs cognitive behavioral therapy, right? So that really needs someone to talk them through their thought process to the actual logical conclusions, because they're always talking themselves into something, but it usually doesn't work out the way they think it's going to work out. So you need someone to kind of like rationally go through the process with them. So I just will give you an example of this. And I think it's important when you're listening to patient, think, am I hearing emotion? Am I hearing people, places, and things triggers? Or am I hearing hyper-rationalism? And that's how you engage with the patient. And for an example, some people have asked me, am I supposed to tell the patient that if they keep drinking, they're going to drink themselves to death? Which could be a fact. Like that could be a medical fact. Am I supposed to tell that? Because some patients have told me that just triggers them. So here's my answer to that. If you're with a patient who's very emotional and you start scaring them with medical facts, then you could cause a lot of stress and anxiety, and that could indeed be triggering. But if you are with someone who's very rational, who's kind of game planning their alcohol use, they might respond really favorably to like adding extra facts for them to think about. So for the rational person, it might really help them to be like, hey, we checked your liver enzymes and they show liver failure, and ongoing alcohol use is associated with blah, 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 blah. And you need to include these in your thinking. And it's going to be really hard to rationalize around cirrhosis and liver failure. And so we need to talk this through together. But if you have like an emotional person, we need to first make you emotionally ready, prepared for challenging information. And I need to give it in a very sensitive way because I don't want to stress you out. It's the same alcoholism and it's the same medical facts about cirrhosis, but it's very different people who are going to respond differently. So the final thing that I'll say is counseling takes time. Like, and you just got to be willing to sit on your hands, be quiet, and let the patient talk, listen. And it actually doesn't take that much time, but for clinicians that, 10 minutes feels like infinity if you're just sitting on your hands listening for that time. And there are sometimes you get into instances where you're like, oh boy, this could take 25 minutes or 30 minutes, and I've got a busy clinic day. So that's a challenge. Also, counseling takes practice. So it's just like talking about suicide or talking about sex. It's going to feel really awkward at first. It's going to feel wrong at first, but then with practice, you get instincts, and it's fun. It's honestly fun. When you start hitting all these points, and hitting is the wrong word. When you start effectively giving counseling and effectively interacting with patients, it's like almost the most fun thing I do. So those are my counseling tips. Any questions about counseling or other approaches?
We have no questions in the queue.
Awesome. This is a super quick one, and I want to hear your input. I'm just going to give 5 things out there that I think are kind of not xylosine is not really novel anymore, but 5 things to have on your radar. Xylosine, obviously, there are xylosine test strips. That's a good idea to get those and give them to patients who use fentanyl. Alpha-2 agonist. So that's like clonidine or dexmedetomidine or Flexeril, and the other one is guanfacine. I think those are all alpha-2 agonists. And so we prescribe some of these, so we kind of know what they do. It's in fentanyl, opioids or fentanyl. And the main effect is prolonged sedation and skin ulceration. It's actually not clear that xylosine is increasing the risk of death. Xylosine might actually be decreasing the risk of death in some ways, in that people are using less fentanyl because they're more sedated from the xylosine. So there's a debate about whether this worsens death or not, but it has prolonged sedation, and patients should really know about, you could be knocked out for 8 hours, just sleepy. And most patients, they want to know if they're going to be vulnerable like that for 8 hours, and then also the skin ulcerations. Medetomidine is a new one that's kind of same mechanism of xylosine, and it's now being found in the drug supply as well. It's unclear what the significance is of medetomidine. Medetomidine sounds like dexmedetomidine, which is used in intensive care units as a anesthetic, basically, or as a sedative. So medetomidine is out there as well. Kratom or kratom, as we know, metragina. It's kind of a mixed stimulant opioid. It can be sold as a tea, powder, or liquid concentrate. And I think I learned on this echo that, wow, watch out for the liquid concentrate. That's trouble. And it's used for lots of reasons. It's really unclear how many people are getting into trouble with it versus it's almost like therapeutic medicinal for some people. I think we still have a lot of questions about the balance of harm and risk with this stuff, but it is being used widely, and it's out there. Tianeptine, I have not personally seen patients on tianeptine, but it's this what's it called, truck stop heroin or something like that. It's a mixed tricyclic with opioid action. It's not FDA approved in America, but it is used as an antidepressant in other countries. And people are using it to self-medicate opioid withdrawal. I'm not clear on how widely it's used or how harmful it is, but it's out there. And then I just picked bromazolam as an example of a street benzo that could be obtained on the dark web and can be pretty problematic. There's a whole bunch of benzos and related drugs, phenobut and other drugs that are sort of like sedatives and get abused by people and can be pretty problematic. I'm curious if people would suggest altering or adding any of the novel substances. This is kind of a quick topic. Just kind of a quick hit. Kurt, is that about right? Do you think? I mean, or would you add? I know you've done a lot of stuff on nitazines.
Yeah, the nitazines are sometimes, I don't know what the percentage is. I know somebody from, I say Haley's on here, she may know. But, the nitazines, especially metanitazine, although I've actually seen a case of the other one that's a little more potent. We see a ton of kratom here.
Yeah.
Just a ton, and the withdrawal from it can be horrific.
Yeah.
I've had 2 teneptine patients, and one of them was the worst withdrawal I've ever seen in my life. She was ordering it from China. It comes under the name, you can buy it over the counter now, called Red Dawn. But it actually was an antidepressant in Europe. And so you can still get it online and get it delivered. So, but the withdrawal from it and the tolerance you develop is very fast. I've had a couple of those that are really ugly.
Got it.
But I think this is bromezolam is the one I've been seeing that people get on the dark web.
Yeah.
And I switch them over to, I've switched most of those people over to Valium or something and then just tapered them.
Yeah.
But it's potent. It's a Xanax-like potency, I think.
Got it. Okay. Awesome. Well, let's keep going. This is metatomidine, where it's been seen. I'm going to just end with this, and hopefully I can move pretty quick. So I think I've talked about this before on this echo. There is a recommendation that all preoperative visits are screened for alcohol and other substance use disorders. All of them. So that is like a huge change in preoperative medicine. And we all see patients going to surgery, and there's a chance that we're going to uncover a lot more substance use and alcohol use and all the rest. So I'm just going to focus on alcohol use because I think we have the most. Okay, but what do we do if they say yes? So I would use the NIDA Quick Screen. First of all, I should add that. Use the NIDA Quick Screen as a screening tool. It's super quick and easy. How many times in the last year, Kurt, how many times in the last year have you had 5 or more drinks on a single occasion? You don't need to answer that, but if the answer is any number of times, that's a positive screen, and I go to the next question. If the answer is no, I have never had 5 or more drinks on a single occasion, I'm done. So once you have that a quick screen, do the audit C, which has been validated as a screening tool for surgical complications. And if you get people to lower or stop alcohol 7 to 30 days prior to surgery, these complications get better. So the audit C is like a complication screening tool. And then screening for cirrhosis. If they have, make sure an alcohol using patient does not have cirrhosis. Get that MELD score and make sure of that, because if they have cirrhosis, you've got to pause the surgery and rethink it. The mortality of surgery is just getting the anesthesia. Their mortality is very high. It could be a hernia repair, something simple. They're in trouble. So, and then if they have alcohol use disorder, do perioperative medicine reconciliation and don't miss naltrexone. And then have a plan for naltrexone for the alcohol use patients who are going to surgery. Minimum, the package insert says 72 hours before any opioids and 72 hours after any opioids. And if it's intramuscular naltrexone, that's going to take 30 days. And then if it's an emergency, it's still going to be 36 hours before opioids work. So naltrexone's a barrier to surgery. You got to document an alcohol user's risk of withdrawal. The prediction of alcohol withdrawal severity scale is a validated tool. But the most important thing, I think, is have they ever had an alcohol withdrawal seizure? Because if they have, you need to document that preoperatively and make a plan, because it could happen in the PACU or on postoperative day 0 or postoperative day 1 when they're recovering from their hip, they have a convulsive seizure. So you got to document the seizure disorders, the alcohol withdrawal seizures, preoperatively. And then separately have a risk for severe alcohol withdrawal should be separately documented, like delirium tremens separately documented, but the seizure thing needs to be in the preoperative note. And then even if they look big, ask them about nutrition. So that's it. Screen everyone, assess for cirrhosis, do that audit C, look for naltrexone on the med list, think about alcohol withdrawal, especially seizures, ask them about their nutrition, and then you can do lots of things to help them reduce or stop alcohol and improve their surgical outcome. And that is it.
There's a question about whether or not you could also use that screen for ambulatory surgeries, and I would guess so, right?
Yeah, the prediction of alcohol. Well, there's a couple screens. Yes, all of them that I mentioned, they haven't been validated in every single scenario. But I think ambulatory surgeries, the audit C includes like wound infections and other things that will be very important for ambulatory surgeries. There are some surgeries like an upper endoscopy. It's not even a surgery. I think that's pretty harmless. That's going to be pretty easy. But I think anything where there's an incision, and certainly anything where there's general anesthesia, I would do all of these steps, whether it's inpatient or outpatient.
Right. There was one question about the potency differences, maybe between xylazine and the other one.
Medetomidine.
The name. Yeah, go ahead.
I don't know. I think the medetomidine is an unknown. I need to research that more. I think that's like a horizon. My theory is that there's a limit to how much xylazine gets made out there in the world. And they're looking for other things because they want to keep putting this stuff in. So they're looking for alternatives so they can expand this. So it's the same mechanism of action, but a different drug. So I think there is not enough xylazine for all the fentanyl out there, and they're looking for other things to put into their fentanyl. But I don't know. I got to look into that.
There's a little question about trying to find it now. But how about the low dose naltrexone, those 4 milligram a day or less, Dr. McClure, was kind of whether or not you've got the same issues with those little tiny doses they use for chronic pain.
I have not used that. And do you mean like in terms of getting it approved or?
No, just as far as the effects of pre-op,
Oh,
yeah, I mean, I suppose they still have to stop it the same number of days in advance.
Yeah, boy. I mean, I don't have a lot of experience with low dose naltrexone. I'm intrigued by it. I would be nervous and just say, let's just pause on that preoperatively, but I've been wrong before. And I would say though, if they are on the low dose naltrexone and they have previously taken additional opioids and they want to stay, I would have to ask someone about the low dose naltrexone because I'm not doing that a lot. That's not part of my routine practice. So that's a really interesting question. I think I would be scared and told them to pause the naltrexone, but I could be wrong on that.
Okay. Any other questions? Somebody just says if there's questions about the presentation later, is there a way that we can contact you?
I'll put my, please do email me. I'll put my email in the chat, or you can also get my email from any of the Echo team. It's okay if you get my email out.
All right.
Don't mind that, but it's in the chat. Narcan does not work on xylazine. Thank you. Yes, correct. It's always fun to do this. It's great to go through that. Any feedback, Kurt or Aaron, later, an hour later, you can give me feedback on the talk. I appreciate the opportunity to share some thoughts.
No.
Can I have your permission to use a couple of your slides for an upcoming Echo?
Yeah.
Because I was taking notes like a mad woman on like rational, emotional. I was like, I've never seen it laid out that way, but it makes so much sense.
Yes, 100%. I'm all open source, non-proprietary slides, steal away, borrow away, whatever, take away. And you could also, sometimes I also illustrate that if it's a real addiction savvy group with the Nora Volkow brain diagram with the nucleus accumbens connecting to the prefrontal cortex, the amygdala, the hippocampus. Those regions are the reason, emotion, memory triggers. So those brain regions correspond with the counseling. I sometimes, for the real addiction savvy crowd, look up those brain diagrams. And Nora Vocal is the classic. You always get more street cred if you name drop Nora Vocal, like the time Kurt was working out next to her in the gym.
Yeah,
Did
I
you
was on
see
a tread-
that
I was
AI
She
thing?
was on a
that-
treadmill next to me, so yeah, it was great.
Yeah.
Did you
What's
see that AI thing that she's working on?
No.
Oh, it's like a device that's supposed to anticipate when someone's going into withdrawal. And I saw her name under the study. I was like, ooh, I'm curious to see what this brings.
Amazing.
Yeah.
Okay.
All right.
Thank
Well,
you.
We're a little past time. Thanks again, Charlie. Fabulous job.
Yeah. Thank you.
2 weeks, we have Cole Perringer coming, so feel free to join that. He's going to talk a little bit about methadone, so it should be pretty fun. Hospital-based.